Rahman Rahim. Thanks, Professor Kamal, for this introduction. And I would like first to thank Professor Salah Naga, Professor Halal Wakil, and Professor Hayam Al-Aggan, and all of the organizing committee of NephroAlex for inviting me, and congratulate them for this very highly successful and progressing conference. Mr. Chairman, my talk today is about the clinical informatics and risk reduction of acute kidney injury. And my agenda, this is my agenda, will include what's clinical informatics and artificial intelligence. I will speak about prediction scores, early prediction and outcome prediction, and biomarkers, including the recent use of NephroCheck. First, to start with clinical informatics, which could be defined as the study of how technology and data analytics can be used to improve patient care plan, how to use these technical data to improve the outcome of the patient. The three limbs of this includes information technology, of course, clinical care, and of course the healthcare system at all. While artificial intelligence is the use of computer science instead of replacing the human intelligence or adding to the human intelligence. In the field of acute kidney injury, artificial intelligence led to an evolution in the specific field of risk prediction models. As you all know, it is important, very important to predict acute kidney injury. Early treatment depends on early prediction. Whatever the early treatment prediction is the good treatment. And this is the early example. Proper recording, especially electronic recording, equals early detection, which is reflected, of course, on the outcome. If we depend on KDIGO classification, this patient's baseline is 0.6, and when it starts to 0.9, this is the point of acute kidney injury. And we can detect this point by sequential recordings. And of course, similarly, this is the sequential recordings of urine output milliliter per hour per kg per hours, and this we can detect at which point the patient reached to acute kidney injury. As a clinical application of clinical informatics is the use of electronic alerts using algorithms configured from patients' electronic medical records and clinical information. These are translated into pop-up alert in the file of the patient. When you open the file of the patient, if this equation is calculated and the patient is calculated to be at risk, this pop-up when you open the file, أول ما نفتح الفايل نلاقي إن في alert ظهر، وممكن الفايل ده يتبعت through mobiles to on charge patient. Your patient is at risk of acute kidney injury, electronic alerts. Does this reflect on the outcome? This is the important question. This is a meta-analysis published in PMG in 2021. They studied over all 6,030 adult patients with AKI and used electronic health record pop-up alert for AKI with an associated set upon provider opening of the patient file. أول ما يفتح الفايل. These are the primary outcomes, included progression, dialysis, death within 14 days of randomization. Unfortunately, they did not be translated into an outcome benefit. And heterogeneity of effect across clinical centers may be the cause. It was a multi-center trials, and maybe, of course, you know, the AKI patient is a very heterogenic patient. So, advanced artificial intelligence, unfortunately, no data on their ability to improve an outcome after clinical implementation, and this was in 2016. It was suggested that, and it makes sense, and with logic, that this approach may increase its effectiveness when we target the patient expected to benefit. Not all patients on the ICU. If we target a certain group of patients that can benefit, this may add to the outcome benefit of this patient, not to disparate our efforts. In isolation is inadequate. Not only the alert and leaving the physician or the physician in charge to do, it must be accompanied by implementing a care bundle show that improved outcomes in patients with acute kidney injury. And we will see later on what is meant by a care bundle. Electronic tag is another application of artificial intelligence or clinical informatics. It is that the patient marking in the patient records as having acute kidney injury before. So this patient, when you open the file, this patient is marked as having acute kidney injury. And this, of course, as you all know, better care, better follow-up, better treatment, better avoidance of nephrotoxic drugs usually will be transmitted into a better long-term care. This was my first part of my agenda, and the second part will be about the prediction scores that includes early prediction and outcome prediction. Unfortunately, disappointing results from several trials aimed at ameliorating AKI once it has developed. As you all know, it is very late to diagnose AKI when it's occurred. And this is the problem usually with all our consultations in the ICU, that we are asked to see the patient later. The disappointing results of serum creatinine, Professor Hayam illustrated before. And the first study to comprehensively use time-varying data to predict AKI was published in 2006, not only to prevent on acute kidney injury or in serum creatinine, but to depend into time-varying data. So a risk score, form a risk score is produced by combination of independent predictors of AKI. Ideally, should undergo external validation analysis. The first step is to implement a risk score. نعمل السكور أولاً what are the points, and then external validation. And this is the meaning of external validation. It refers to how well the outcome of the study can be expected to apply in other settings. How can we apply this score outside the setting of our study? So the risk score leads later on a validation studies. And the most famous risk score we used, of course, is the contrast-induced nephropathy risk score we use also every now and then in our clinical life. Either risk prediction score, and these are examples of the data to be used in the score. Of course, epidemiological scores, biological factors, format of demographic, clinical, biological factor, along with biomarkers. Age, gender, baseline kidney function, CKD history, diabetes, liver failure, heart failure, and the use of drugs in combination with liver biomarkers. So we can construct a risk score for prediction, early prediction, not only from serum creatinine, but combination of multiple data. The most two famous of those are Malhotra score, easily calculated one in patient critically ill setting patients, and Filchet et al. With wise availability, which were both available online and can calculate the risk. This is Malhotra risk score, format of chronic variables, chronic kidney disease, chronic liver, congestive heart failure, hypertension, and atherosclerotic kidney disease, or acute variables, including metabolic acidosis, nephrotoxin, severe infection. More than 5, the patient is high risk, and less than 5, the patient is low risk. Limitations of these scores include lack of external validations. We use the scores without sufficient lacks of external validations, and I will show you that systematic review failed to show a benefit of these scores in systematic validations. Heterogeneous definitions of acute kidney injury. What is acute kidney injury exactly? What is the stage? Are we in risk or stage? You know all that it is heterogeneous for difficulty in assessing the baseline renal function and lack of evidence of clinical use. This is an example of limitation. This is the Gay-Diagon definition we use for acute kidney injury. Creatinine, baseline creatinine rise more than 0.3. So what is the baseline creatinine? This is an important question. What is the baseline creatinine? Is it the previous creatinine before? We usually find a difficulty in history, or the admission creatinine, one at admission, or that pre-procedure immediately, pre-contrast, pre-operative. We fail to find this way. Many antibody studies for outcome prediction. And finally, this meta-analysis showed that was 12 single-center studies, included more than 1,000 patients for external validation of scores, and they showed poor discrimination till now of AUC 0.7 and poor discrimination of early prediction of acute kidney injury, unfortunately. So the important is external validation studies. Cardiac surgery is a rich is a rich area of innovation in this field, including many perioperative variables. And this systematic review for cardiac surgery was done, risk scores, and they concluded that further studies are required to develop risk models, milder non-dialysis requiring AKI. All of these scores were for dialysis-dependent acute kidney injury. Surgeons think of AKI that dialysis usually. So the problem in non-dialysis kidney injury. The most famous is Cleveland Clinical model, and we need a non-dialysis requiring AKI. This was our study for validation of Malhotra score in Asr al-Aini. And we randomized the patient into two arms, observational arm and interventional arm according to the score. This score, less than 5 will be in observational arm and or more than 5 in interventional arm, or were critical ill patients. And this is the care bundle we applied for the patient with high risk, including the most important item is early meticulous nephrological care, including the usual items you all know. Discontinuation of all nephrotoxic drugs, volume status, functional hemodynamic monitoring, tight glycemic control, and considering drug doses. No AKI at presentation, patient was matched, and these were our results. Application of this score and validation resulted in lesser acute kidney injury 48 hours. 30 days mortality were lower, although non-significant. And all secondary causes and incidence of dialysis, deterioration of AKI stages were lower non-significantly, while time till recovery were significantly lower. Coming to your biomarkers, nephrocheck, many biomarkers are present now with variable results and variable significance, specificity, and sensitivity, and they have many limitations. Differentiating pre-renal from renal, wide range patient variation, increased cost, need for multiple assessment or combination of multiple markers, and evidence of outcome improvement, of course, is still lacking. And this is the important point. هنعمل ايه من غير الاوتكم؟ يعني without outcome هيبقى الموضوع يعني theoretically based تماما. احنا القصه كلها ان احنا عايزين نعمل early detection for acute kidney injury, وده will be translated into a better outcome. The best performing, as Professor Ayab mentioned, are IGF binding protein 7 and TIMP because they are markers of cell cycle arrest. In sepsis-induced acute kidney injury were thought to be due to apoptosis. And this study in 2013, renal biopsy from 44 septic patients against 20 controls, no apoptosis. So what is it? It was found to be cell cycle arrest mainly for sepsis-induced acute kidney injury. And this cell cycle arrest was at the level of mitochondria. So factors aiming at cell cycle arrest are of important factor and most specific. This was the principle of nephrocheck. Urine sample in this apparatus, if they approved, we study urine TAMP, IGF binding protein 7, and this is the equation to calculate the results. 0.3 cutoff with high sensitivity for more than 0.3, patient at high risk, while lower than 0.3 cutoff is lower incidence risk of acute kidney injury. This study applied the level at admission in ICU in associated kidney injury in the first hour, probably due to the short half-life of these markers. Also, intraoperative rise of this equation or this factor was studied with variable results. Possibility was proposed in this study 2019 to identify patients who could have evolved from AKI to CKD, but still the cutoff point is still not defined for this. It is defined only for acute kidney injury. Limitations on course include at which stage of acute kidney injury we are, rifle 1, 2 risk stage, and false positive results. In cases of urine dilution, as high IV fluids and low risk patients could not be differentiated early low risk or late low risk. Another method for early detection is the renal Doppler. Elevation of renal resistivity index in patient at risk was found to be representative of risk of acute kidney injury. But unfortunately was found to detect it lately. And combining the renal Doppler with TMP2 and IGF binding protein 7 was found to increase the sensitivity of this procedure in early detection. As for example, in this study, in thoracic cardiac surgery, Most of the prediction scores and most of the studies in prediction of acute kidney injury, or a lot number of prediction, came from surgical patients, unfortunately. We lack a number of medical patients are somewhat less. Possible to increase the ability of the test by use of renal sensitivity index in addition to these markers. This was our study on this point in Yasser Al-Aini, role of interleukin 18. Yasser Al-Aini kidney injury molecules and renal sensitivity index as early predictors of possible. Combined the three markers, IL-18 and CAM1, and in addition to renal sensitivity index. It is considered for publishing in Saudi journal. Regarding AKI prediction, we found that the best is using ROC curve, CAM1, followed by renal resistivity index. While regarding logistic regression, the same results were found. Also regarding mortality prediction, the best was for resistivity index, followed by interleukin 18, and logistic regression resistivity index alone was found to be. So resistivity index could be an important point in this area of AKI prediction. So Mr. Chairman, in my conclusion, AKI prediction is a rich field of scientific innovation, and very heavy work is undergoing in this field, aiming at prediction. Unfortunately, more studies are needed now for validation of AKI risk scores, rapid biomarker check, and e-alerts. In spite of this plethora of studies, we did not find strong evidence and good solid data now. Bedside AKI prediction could be an easy and common future practice, and we hope to make it yearly. Please remember that in some time of history, this worm caused a major harm to this man and was solved by these few tablets now. And this virus caused a major harm to this country, again solved by this drug now. So we don't know at which place of the story we are. And thank you very much.
Thank you very much, Professor.